Dr. Rinella, that is fantastic. Thank you for enlightening us. The journey of NAFLD to MASLD and the NAS to MAS. Now the topic is open to discussion. Please raise your hands if anyone has any questions, so we can go from one person to another. And I know that there are several experts from around the world. They're represented by many countries here, and many of them are part of the steering committee as well. May I ask Dr. Sivram Singh from India first to chime in? Dr. Singh, you've been part of the steering committee, and your comments first. Do I see Dr. Singh here? Anyone else, please? Dr. Dokumersi?
It's excellent talk, really. Thank you very much. Actually, we didn't know that the importance of the liver steatosis just 25 years ago, but now steatosis is the most important cause of the liver diseases and also liver decompensation. But the problem is still is the nomenclature. I think the study, especially from ASLD, EASL, really they are doing very well. And one of Turkish guy, Professor Yusuf Yilmaz, also really having a lot of contribution to this study and published many articles. And also as a puzzle site, also we had a study group, and we are taking care of the nomenclature of the liver steatosis. I think the most important point is the consensus of the liver steatosis. Maybe we can have the combined study, combine some conferences, and we finalize the nomenclature of the disease. Thank you very much.
Thank you for your comment. So I do want to emphasize that a puzzle was included actually from the very beginning in this process, including actually Dr. Yilmaz, including Dr. George, including Dr. Eslam. They were actually on the steering committee, and they participated in the first 3 rounds of the process, and left in the last round. So they were in the process from the very beginning. And so I just want to make sure that that's clear, that we all understand that. So from an ASLD and EASL ALE perspective, the nomenclature is, this is the nomenclature that we are taking forward. So we are, happy to engage in discussions, but the nomenclature is not, this is not, we can't change it. We went through a long, transparent process with good methodology, so we can't really change it again unless we go through a whole nother process, which I'm definitely not doing. Somebody else can do that, but not me. So, but thank you.
Those of you who don't know, Dr. Okumersi was the president of APASL several years ago. I can ask Dr. Ajay Duseja, who is called the NAFLD Man of India. He has been a pioneer in that, a lot of work that's coming from India. Dr. Duseja, please.
Thank you, Sanjay, for that introduction, I would say. And very nice talk, Dr. Rinella. I think really enjoyed that. And, putting the INASL perspective or the Indian National Association for Study of Liver, when this nomenclature of NAFLD came in 2020, and that was a COVID time, I distinctly remember. And, that was the time when, INASL were, we were actually forming our working party to come out with our new consensus guidelines, because our earlier consensus was in 2015. So we intentionally included nomenclature into our guidance paper. And if some of you have seen our guidance paper, which came out in 2022, we distinctly said that we were not agreeing with NAFLD. And that time, this Delphi consensus had really not started or just started. I think just started, I remember. So we said that we are okay with NAFLD for the time being, but we would look for a better, nomenclature. But when the MASLD came as a Delphi consensus from EASL and ASLD, and a lot of societies were approached, and we were very, very happy to support, MASLD as the terminology. And the Governing Council of INASL decided that, yes, we will endorse MASLD, and we stand by it. And in our national meeting, which happened in August this year, which was projected by Dr. Rinella, the symposia which we had, actually we named them as MASLD rather than NAFLD. But the challenges and the other reason, which again our paper was quoted by Dr. Rinella, which was analyzed by my colleague Orko Day, where we looked at that when we applied both these definitions, MASLD was a little more inclusive, especially for lean patients. And the reason for that is basically threefold. One is that the MAFLD was also suggesting the usage of, biomarkers like CRP and HOMA, which is usually not done in clinical practice, at least in India, number one. And the other advantage of MASLD is that MASLD takes into account central obesity also as a cardiometabolic factor. With that, a lot of our lean patients get included. So I think these were the two reasons we thought that for lean patients, the MASLD is much better than MAFLD. Now, the challenges before us are basically three. One is, we have a INASL task force on NAFLD, so we need to change that nomenclature. We have an Indian consortium on NAFLD called ICON-D. So, that also needs to be changed. The acronym, everything needs to be changed. And more importantly, the NAFLD has recently been included in the National Program of India, NPCDCS. So I think then the regulators and all these need to be approached, and they need to be told that this new name for NAFLD is MASLD, and accordingly, the program, it's a national program. It has to run, it has to go to the ground level, and many things need to be done. And obviously the drug approval and other things, for example, the saroglitazar in India was approved for NAFLD, and there would be other drugs, which would be coming in the pipeline. So I think all those issues remain. But having said that, we are very happy with the new terminology with MASLD now. And thank you very much, Dr. Rinella, for highlighting that.
Thank you, Ajay.
Thank you, May. Now, Dr. Singh, I see you back in the meeting. Dr. Sivram Singh. All right. Dr. Prasoon Jalal from Baylor.
Oh, that's great. It's a wonderful talk, as always, and Dr. Rinella. I have a question. It's a different context. How do you explain to the patient? I know the patient's representative is over there. How do you explain to the patient you have MASLD? It's very easy for me to tell, okay, you have non-alcoholic fatty liver, you don't drink much, so you have got fatty liver, whether this is because of your metabolic, dysfunction or medication, many other causes. Now, here I write in the patient, after visit summary from practical point, oh, you have MASLD. So how do you really give the message to them what it is?
Well, I think it helps. That's a good question. So I think part of the reason I think we're so comfortable with NAFLD is because we've been saying it for 20, 30 years, right? So that's why I think it's very easy. The truth is it's not non-alcohol in some patients, right? It's a little bit of alcohol, first of all. So I guess what I start by saying is you have a sort of abnormal metabolic state where you are predisposed to put, fat in your abdominal cavity, and that leads to the accumulation of fat in the liver. I use the word fat in the liver. That's not, when you're describing sort of how the disease happens, I think it helps. And that's why, because of the disordered metabolism, you also have, associations with diabetes and high blood pressure and abnormal triglycerides and cholesterol, and all these things, together work to worsen liver disease, right? So I really try to focus on, it actually helps me in a sense explain why they even have this in the first place, because saying that they don't have it from alcohol doesn't really help explaining why they have it, right? So I really use it as a sort of springboard to explain how we treat it, right? How do we treat it? We treat it by reducing abdominal adiposity. We treat it by improving insulin sensitivity. So countering all those abnormal sort of metabolic states. Does that make sense, Prasoon?
No, sure. The other question is, I mean, obviously, it's easier to say you have got fat in the liver than steatosis, but this is
But
more.
I still say that. I still say that.
Yeah.
Yeah, it's okay.
The question is about the alcohol.
Yeah.
And obviously you have met ALD, but why did you, I mean, put the amount in such a way? It's, as we all know that the amount is not same from European or Asian or different population. Also even NASH-CRN, their limits, 20 gram for male, 10 gram for female. So why did you keep this high threshold?
Yeah, that's a good question. So because we had to, okay, for this, and the reason is that if we shifted the threshold to say what NIAAA now considers to be significant impactful alcohol, then that would change the population, right? So we were a little bit stuck with, the population as NAFLD was defined, which is 20/30. Okay, so we couldn't dip below that because then it would impact on that population that we needed to emulate, essentially, right? So in order to capture a population that consumed more than that, and many people do, they just don't tell you that, then you're at least able to do that. From a clinical perspective, to me, Met-ALD is a dynamic spectrum that's it's not a defined construct, okay? To me, it matters less if it's, they drink 50 grams or 70 grams, because to me, I'm addressing both issues. I'm addressing excessive alcohol use and cardiometabolic risk. And the same goes for the alcohol community. I think they under-addressed the cardiometabolic risk. And so I think it elevates both of those things in importance. So I think that's the point of it. The reason for the upper bound limit is just because we had to put it somewhere. Okay. And that's more from a research perspective. And there are actually some studies coming out from NHANES that show actually a division in those subgroups. So it's actually useful from a research standpoint, but from a clinical perspective, to me, Met-ALD encompasses the whole spectrum after, minimal or no alcohol use. If that makes sense.
Great. Yeah. Thank you.
Thank you. Dr. Manas Manigrahi from All India Institute of Medical Sciences from India.
Hi everyone. Excellent talk, Dr. Rinella. So just one question. So since this change in nomenclature and all those things are based on the central point is metabolic dysfunction. Am I right?
Yes.
So metabolic dysfunction from our group, we have seen in this part of South Asia, we have seen in our cohort, one cohort that is published around 171 normal population, they normal volunteer. They have BMI of around 22 or so, 21 and 21.2 and so. So in that normal population, we have looked into, and if we use ATP criteria, ATP3, then they have metabolic dysfunction with around 8.8%. And when this NAFLD, that name change happened in 2020, and we have seen in that population, and that has been published, around 33% of that normal population are become metabolic dysfunction. And when this MASLD now came, and putting that criteria, metabolic dysfunction criteria, cardiometabolic risk factor criteria to that normal cohort, that 171%, now we are getting metabolic dysfunction in 77% of the normal cohort, that is 171%. So how to interpret this, how to go ahead with this? Can we say that this normal cohort are going to develop steatosis or fatty liver in near future, and you have to tell them that normal BMI people 21.2 or something, whether we have to one red sign we have to give them, or how to interpret this thing?
Yeah. Well, we do know that having things like pre-diabetes or diabetes increases your risk of incident steatosis 2 to 4-fold. So we already know that. And I think that yes, I would say they're likely to develop steatosis potentially in the future, or they're more likely than if they didn't have cardiometabolic risk factors. But it doesn't mean, I don't think we have enough information to be able to say you should follow them at X interval. If they don't have steatosis, unless they have advanced fibrosis, of course, because you lose steatosis in that setting, then I would say you would follow them like you would normally follow a patient without any specific interval in mind. I guess we don't know enough to know what the interval would be. That's the question you're asking.
So, but that group, Dr. Rinella, that group are BMI is within normal limit. They don't have diabetes. They don't have fatty liver in ultrasound, and so it is difficult to interpret that group. Then most of the population, if you'll cover this definition, they will come under this metabolic dysfunction.
Well, but they have to have steatosis, though, right? They have to.
No, they don't have. These are normal people.
Yeah. So, at some point, if they do develop steatosis, then they would meet criteria. If they don't develop steatosis, then they would not meet criteria.
Okay.
Thank you.
Thank you.
Dr. Masumi, Clinical Director at Lenox Hill Hospital. Unmute, please.
Good morning, and thank you so much for giving us this platform and opportunity to talk about it. First of all, it's a great thing. It's wonderful that we are working on nomenclature of such a widespread disease. Let me give you a couple of disclaimers. I've never written any literature on this, so I'm not an expert on the academic side. On that curve, I had no expectation to begin with, so there's no disillusionment. We were all aware that NAFLD was a terrible name. We all knew it. I always make an example. There's no non-cocaine acute MI or non-drinking car accident or any of this. NAFLD was terrible. But then we came in, and I really appreciate you helped me because Prasuna started it. I was planning to keep quiet, but then Prasuna started it. So I want to give you, I want to give you a perspective into my practice in New York City. There's limited access to hepatologists. Everybody has 3-month wait time. I don't, because I keep adding patients to my schedule. So I don't have 3 months wait time, but I go home at 9 p.m. And now we have one more complexity to a condition where there is no obvious treatment. Yes, there are some medications you could use if they are diabetic. If they're not diabetic, vitamin E, a paper many years ago, with all due respect, no one has ever addressed the prostate cancer issue in male. No one has ever addressed the cardiovascular risk. Mm-hmm. And now I have an EMR explanation of NASL, and I have difficulty to explain it even to patients. I say, yeah, you have fat in the liver, which comes from your probably calorie intake, too much carbohydrates. And I write a note to the primaries, and I try to communicate with them. And I feel like at the time of really struggling with this disease, really struggling with liver disease, I mean, if you put into perspective, even transplant, we are putting organs coming from people who had, unfortunately, a good portion of them drug overdose into an organ, into a person who had another drug overdose called alcohol liver disease, alcohol-associated liver disease. And then there's now another complexity. So I'm not asking for an answer. I'm just trying to explain it why there are people like me who behave like a Grinch, because it's just difficult. And but it's great. I mean, it's, in that 20, 30 minutes time we have with the patient, we have no access to dietitian. The company which makes the FibroScan cranked up the price, so access to FibroScan has been limited. So as I really appreciate if the whole society can push for other matters in the management of fatty liver disease, which would help diversity of access for our patients, etc.
So thank you for that. And I will say, I encourage you to think about, it's not actually more complicated. You're really just putting a description to what the disease already is. So it's not really making it more common, but I will say, I completely understand. I just put in the chat a website that you can potentially show your patients. So this is a project that I've been working on for many years, and particularly because we need to provide a way to educate patients to eat better. Nutritionists aren't covered by many insurance plans. And so this particular website helps link people with dietitians, essentially, and it provides education and awareness. And eventually it'll do a lot more than that. It's just in its infancy right now. But I completely understand. It's very difficult. It's hard in 20 minutes to cover all the things you can do, for a patient like this. There are things you can do more than vitamin E, but it takes time. You're 100% agree with you that it takes time. But I don't think that the words change that truth, if that makes sense. But I think it's like anything, getting used to it. So
no, you're absolutely right. The very last comment I have is also about the alcohol. I mean, yes, these two diseases are pathophysiologically, and if you biopsy them, somehow have some connections. But educating is like they are completely different diseases. I mean, if you have fatty liver with elements of fibrosis, you should not drink.
Of course, I agree.
Based on, that wonderful paper, I believe Dr. Chalazani wrote a paper or an editorial saying, first, do no harm. I mean, if patient walks into the office, if they are post-transplant, we don't tell them 2 shots are okay or 3 grams is okay or 30. You can't drink. I mean, period. You should not drink. And it's the same thing. So if we go like that, then we should have like Met Hep C, Met Hep B, or ALD Hep C. And then it's like, Jesus,
you could. But remember, though, yes, you're right. But remember that that one of the primary manifestations of liver in the liver from alcohol use is steatosis, right? So that's the reason to have that particular combination called out, because they both lead to they act by many of the same pathways. So it's not like, yes, you could say genotype 3 Hep C with but really it's not the same. Autoimmune doesn't look the same, but liver steatosis from liver disease can be very similar in appearance and pathophysiology, at least. So that's the reason for that. So
thank you very much.
You're welcome.
Those are some very interesting comments and thoughts. Thank you, Dr. Somi. And may I invite Dr. Maliakal from Nashville, Dr. Benedict Maliakal, and then after that, Dr. Sanjeev Sahgal. Dr. Maliakal, please.
Hi, that was a good talk, but as a clinician, I don't think anything changes, because MASLD is like a total umbrella term that includes alcoholic hepatitis, alcoholic liver disease.
No, it doesn't. It doesn't. No. SLD, so steatotic liver disease, includes MASLD, MET ALD, ALD, and then all the other specific causes. MASLD, it does not. Yeah.
But it's still an umbrella term, because, people, when we used to do EEG for people with encephalopathy, neurologists would say metabolic encephalopathy, which includes, it's a catch-all term. Where the rubber meets the road, nomenclature, it doesn't make a big difference when I'm talking to a patient. And I agree with Prasun, and when it comes to clinicians taking care of patients, we have to talk about all these issues: alcohol, diet, etc. And you cannot get fatty liver without a metabolic dysfunction. So so in that respect, it doesn't make any difference. I mean, this looks like it is more stigma issue. I mean, I'm surprised that sexually transmitted disease term is still being used, because that stigmatizes patients. And I'm sure it is coming. It's just the sign of the times. So I honestly, when it comes to clinical practice, I don't think nomenclature changes anything.
Yeah, no, that's fair. I mean, we had a lot of discussion over the term metabolic because, to your point, what does that even mean, right? What does it even mean? Because and where we ended is that, yes, it's technically everything is metabolism, but people understand what you're getting at. And that was the conclusion from the survey and the discussions, was that it's not a precise term. In fact, I was actually quite against it, to be honest, but it wasn't about what I particularly wanted. I wasn't very for that because of the ambiguity associated with that. But it sort of conveyed a concept that people understood, if that makes sense. And that's why I think we ended there, to be honest.
Thank you.
Thank you, Dr. Sanjeev Saigal, a prominent hepatologist from India. Dr. Saigal.
Thank you, Sanjay, firstly, for bringing this wonderful talk from Professor Rinella. It's really a thing which we need, something which we've been looking forward to. I've been a part of, INSL task force on fatty liver, the ICON-D, for, years together. This will surely be of great benefit for all of us. The only thing which will be a bit of gray zone in this entire classification is the Met-ALD, particularly because in our Indian practice, I am not sure how many of us take that history of alcohol so carefully. How much is the patient really willing to tell us clearly? And so that quantification part is something gray. Secondly, many of patients have seen, I've been in transplant for almost 2.5 decades now. The liver involvement with alcohol is so different, from various parts of even our own country. People from northeast and the northern part of India and south, they're so differently behaving. So therefore, this will be a bit of gray, which we have to work out. It's our responsibility to make clear that we are able to use this definition in a very accurate way. And two questions which I would like to have. One is that somebody is, Met-ALD, but somebody is MSLD predominant, and that person over the period of time starts taking alcohol. So does he changes his level of diagnosis? That's one thing. Secondly, can we have is there potential for some biomarkers which make it more clear about the history of alcohol? Patient may be lying to me. That's a very common thing in my OPD practice. They come with their spouses, with the parents, and then they don't give up their alcohol history. And so my entire diagnosis will be in error. So are there going to be any biomarkers which will say that, yes, you have got this thing, alcohol level of so-and-so, so therefore you are ALD, Met-ALD, and not MSLD. So, but otherwise, I must compliment you for this excellent work which you have led and given light to the entire thing. Thank you so much, Professor Rinella.
Thank you. Thank you very much for those comments. So with respect to Met-ALD, again, I see it as a spectrum that elevates the importance of both things, right? So just from a conceptual standpoint, we need to ask all of our patients about alcohol consumption, about pattern of alcohol use, and we need to do it regularly because patients' alcohol intake fluctuates, and it's important. I think it's also important to recognize and help people feel comfortable with the fact that we're not going to, judge them or treat them differently, other than, that they need to understand that there is a synergistic impact of alcohol use when you have cardiometabolic risk. And so I think just getting us used to having that conversation is very important. And so from a clinical perspective, you're just addressing both things in a more top of mind sort of way than I think we were before. I can at least speak for myself, and it sounds like for you and in India as well. So I think that's really important. With respect to the actual thresholds, I don't think on a clinical level it matters that much, right? Other than, you start to get an idea if somebody's really, really drinking a lot of alcohol, well, then that needs to be an important focus. They may need therapy for, alcohol cessation, et cetera. But really it's a clinical impression. With respect to biomarkers for alcohol, there are biomarkers. They're not accurate enough that we use PEth. Okay. I would love to be able to have a test where we can say, this percentage is from alcohol, this percentage is cardiometabolic risk. We do not have that. And then also added complexity is that within an individual, genetic predisposition has a huge role to play, right? So what's too much alcohol for you may not be too much for me, although it probably would be, but, you know, et cetera, you know, so it's very different from person to person. So I just think it calls for us to be better doctors and have more, pay more attention to more things and advise our patients to have a healthier life in general. So.
Right. Thank you so much. And we look forward to more work from you in this area. Thank you so much.
Thank you. Thank you, Dr. Sehgal. May I ask Dr. Massimo Colombo, you know, how this name change has impacted your practice and your comments, and please introduce yourself, Dr. Colombo, as well. Unmute, please. Unmute.
Work it out. Okay. Okay. Good afternoon, at least from Milano. I spent my life working on viral hepatitis B and C and liver cancer, and then I jump into this NAFLD or MAFLD or SLD, as we call it now. And I'm very much pleased to say that the last efforts to generate a new nomenclature, taxonomy, was worthwhile and helped to better understand what the role of a clinician is. In Italy, liver disease has been very initially handled by infectious disease experts and subsequently by gastroenterologists. Here, we are dealing with a multidisciplinary approach that has to do with internal medicine. So, in my opinion, is a sign of a return of liver disease in the domain of internal medicine, where, in my personal opinion, should stay. And as an expert in liver transplantation as well, I've always been practicing in terms of internal medicine, and I'm happy to say that SLD makes me more confident because I understand that I have to interact with other specialists to deal with these patients. In Italy, as elsewhere, there is a situation whereby is a hybrid disease because, as you said already, the role of alcohol is important, particularly in an area where Italy, where social drinking is so diffuse. We are now experiencing, the onset of binge drinking, which is making things more clearer, at least in a set of the patients. But the vast majority of my SLD patients have, in fact, alcohol, a latent or a subclinical alcohol abuse, which comes from, a social pattern of drinking. That said, what, in my personal opinion, is still missing is a closer look at the histopathological findings in this disease, because, as a consequence, as an inheritance, as a legacy of liver cancer, we forgot liver biopsies in the last 25 years, which, as you know, poses a number of issues in the management also of management of liver cancer first. And here, I see that many colleagues of mine are, defining NASH without having histopathological findings available. So I think that is still a confused area, and then we need more training, more, I think a vast majority of colleagues of ours here needs to be chaperoned to a better practice of medicine and going back to liver histopathology findings before categorize patients as having NASH versus less severe liver involvement. Okay. Thank you anyhow, Dr. Rinella.
And thank you for that comment, Dr. Colombo. So I will say that I also am I'm very tied to liver biopsy. Okay? I feel like I can see it, I can understand it by looking at under the microscope. And so I am probably one of the later people saying, okay, we have to at some point disassociate ourselves a little bit, and I'll tell you why. The reality is that only 7% of physicians are doing liver biopsies, right? So we're not going to be able to convince more to do that. There's a very, very strong push against liver biopsy from a patient perspective, which, you can say, okay, maybe they don't understand how important it is, but the practical point is, as the burden of disease is so high, we have about a 30% prevalence of the disease globally. You cannot possibly do biopsies on all those patients. And so I think that some of the work with biomarkers that are trying to get at people who are likely to have steatohepatitis with fibrosis, which are the ones that are going to have adverse liver-related outcomes, The performance characteristics of biomarker approaches are decent, are getting better actually. So if we can reach a point at some point where we can say with fairly good confidence that we're identifying somebody with steatohepatitis and fibrosis, I think we're in a good place if we can actually do that. I think realistically, we're not going to be able to biopsy everybody. It's just not going to happen. It's not even happening now, or wasn't even happening, say, 5 to 10 years ago. So I think we're stuck with it. And I still love looking at liver biopsies. I order them all the time, but most of our colleagues don't. So I have a microscope in my office.
You know, I have a bias because I was trained in America at the department of Dr. Popper at Mount Sinai Hospital.
Yeah, of course.
Decades ago.
Yeah. All right. Well, the giants, of course, but yeah. So I understand what you're saying.
You know, so I really was, you know, my bias. One of the major limitations in prescribing liver biopsy is the lack of an effective pharmacotherapy. Quite clear to you, of course, limits. But I must tell you that we came across the diagnosis of PSVD. PSVD was ignored, was overlooked. You know, this portosinusoidal venous disease, which might in fact present exactly like an NAFLD. You know, a little bit of GGTP, a little bit of transaminases in the fully asymptomatic liver patients. You cannot go through imaging diagnosis. There's nothing. But liver biopsy would reveal PSVD, which, you know, only in 10% of cases is clinically meaningful, but, you know, just to separate, to disentangle the two diagnoses.
There's still a reason to do a biopsy, though. We still have reasons to do liver biopsy. So if, you know, if there's any uncertainty, if there are markers that are not working, if there's persistent elevation of liver chemistry tests, so there are lots of reasons to still do a biopsy. I still do biopsies all the time. So
yeah, good. Happy to hear that.
Yes.
You again, thank you. Anyone from China or Hong Kong in that area, please also raise your hands. Would like to see, would like to listen to your perspectives. So in the interval, may I ask Mohammed Al-Faki from Sioux Falls, Dr. Al-Faki? If not, yeah, he's still there, but I think.
Oh, sorry, I was on mute.
Okay.
Thank you very much, Dr. Rinella, for the excellent presentation, as always. So I have a question. In my practice, sometimes I try to use ELF to determine those patients in the indeterminate range when I do the FIB4. So, and the ELF came back beyond the 9.5-10 range, which is concerning for significant advanced fibrosis.
Yeah.
And I follow that with an MRI elastography because the patient is pushing against biopsy, and the MRI elastography come completely normal liver stiffness. So this has happened frequently to me in the last few months. And multiple patients, it leaves me in a blank spot to biopsy them ultimately, which they don't want to do. So I was wondering why this conflicting result between ELF and MRI elastography.
Yeah, so no, you're right. In fact, we do recommend ELF as an option, okay, for secondary risk assessment of people with FIB4 is greater than 1.3. But the thing to remember is that the performance characteristics of ELF were tested in a population that were in advanced fibrosis. So there was really, the performance is really meant to be in people with F3, F4. Okay, so if you take a lower prevalence population, like you may be seeing, for example, you may not have as much accuracy. So I would be, if you have the benefit of an MRI that's showing you that there's no increase in liver stiffness, the negative predictive value of MRE is very, very good. So I would probably say that's sufficient to exclude advanced fibrosis, despite what the ELF showed. Now, you could also say, because there's a discrepancy, you could opt for liver biopsy in that case. But MRE, if your question is, does the patient have advanced fibrosis, which is what ELF is going to tell you, I would say MRE is going to be better and more reliable, negative predictive value-wise. So.
Perfect. Thank you so much.
Thank you. And I know Dr. Reda El-Badawi from Egypt, she had a lot of interest in fatty pancreas and has been working in that area. How this has impacted this name change. Dr. El-Badawi? Yes.
Hello. I'm very happy to be with you, all of you. I'm very thanks, Dr. Mary, for this good lecture. But I'm right in the chat and the comments that this will change our practice with the patient, as I'm a clinician. Fatty liver with MASLD or MAFLD or whatever the nomenclature that it's done now, it is well not different, because the patient may come with atherosclerosis or hypertension, cardiac manifestation apart from fatty liver. He didn't complaining, and we will discuss that by ultrasound or any other investigation. So I think this nomenclature, it will not change our policy in the treatment. This first one. Second one, as Professor Sanjaya mentioned, I'm interested now to the study of that of fatty pancreas with fatty liver. I think it's triple times prevalence of fatty pancreas than fatty liver, that pay our attention all as a clinician to be in that area now, because it will lead to diabetes mellitus more than fatty liver. What's your opinion as regards that? This is my interest now. This is fatty pancreas and microbiome.
So no, that's very interesting. I don't know much about fatty pancreas. That's certainly not anything that you would ever know. I mean, so I can't say too much about that specifically in this context. Although I do think this speaks to a multi-system problem and a multi-system disorder. So it's really the person that has these this dysfunction that it manifests itself in many different ways, whether it's atherosclerosis or fatty pancreas or other manifestations. I think it's just part of a systemic problem. The problem, you're right, is not in the liver per se. I mean, some things in the liver are obviously not working properly, but it really is a systemic problem. That this is just one of the manifestations of it.
Yeah, that is what does it mean, that we are in need to express more and care more for the extrahepatic manifestation, because most of the people, especially the young one, dead from cardiac arrest due to atherosclerosis.
Right.
Yes.
And most people from MASLD die of cardiac disease too, and cancer. And so that's why, the good news is that the treatment, the most effective therapies are really getting at the root cause of the disease. And so if you take as an example, GLP-1 or GLP-1 dual or triple agonist, you have a reduction or a change in the visceral adipose tissue compartment, less inflammatory signaling, and less cardiovascular, cardiorenal death as a result of that. So I think a lot of our approach needs to be at trying to treat the underlying disorder.
Okay. We are okay. Next time to talk more about that fatty pancreas, because it's very serious. Yes.
Well, you'll have to talk about that. Yeah, not me.
Yeah. Okay. Thanks a lot.
Okay. Thank you. And may I invite Dr. Mangesh Pagadala from Houston. Dr. Mangesh, did I miss him?
Hi, Dr. Rinella. Can you hear me, Ma?
Yes,
I can. Thank you.
Yeah, it's a pleasure as usual to listen to your talk. And I totally agree with you that biopsy speaks a lot. I mean, my mentor is Dr. Arthur McCullough. And I did a lot of work with him, and he was very instrumental in a lot of things with NAFLD, etc. But coming to the question of nomenclature, and then I'll ask you another question on fatty liver disease per se. By changing the name, obviously nothing has changed. All this 40 years of work we've done, we still don't understand pathogenesis well, because there's a lot of pathways. We still don't have a therapeutic option, because obviously we still haven't got a grasp on pathogenesis yet. Now, this nomenclature business, I think, is just more like coming in from people who want to just change the name for the sake of patient stigmatization. And do we have any data? I mean, hepatology is all data-driven. Did the American Association of Liver Disease get patient data before? I know this was a lot of push from European associations more than American. I think we were more in a more comfort zone with what we're doing. Is that a fair statement to say?
I think that the biggest driver, to be honest, of this happening was really related to the 2020 publication, to be honest, because even though we all recognize, I mean, honestly, if I could have had, I didn't choose to, I didn't wake up one day and say, I just want to out of the blue change this. Okay, this is not how that happened. So this felt like it was an existential crisis for the field in the sense that we were seeing a very significant adoption of a new definition that was going to significantly change the work that had been done and that was in progress with respect to biomarkers and therapeutics in this space. And we knew that there were medications that were very soon to be probably approved. And so there was a sense of urgency, I think, from that perspective. So no, there was not a national or international survey on, how people felt about it. That takes a very long time to do. And I'm sure you recognize that stigma is really about who you ask, right? That's how you know. I mean, you're going to get a very different answer from different people that you ask. So there was a sense of urgency because we felt that the worldwide adoption of a definition that was going to be problematic from a natural history perspective, that was sort of the impetus for it. So it wasn't like there was a particular analysis done prior to that, if that makes sense. And I will say that there are actually, we will likely have a drug approved within the next year. Actually, so we have made good progress, actually.
And some of my patients kind of equate liver disease with alcohol, and they feel it comforting when I tell them it's non-alcoholic. And how we kind of take the name away.
But you can still tell them it's not related to alcohol. But then also remember that for alcohol-related patients, there's some stigma in constantly referring to, oh, but it's not alcohol. Well, at least you're not one of those people. That's essentially what people feel sometimes. So I think that you still tell them it's not from alcohol if they ask you that, but it shouldn't be the only defining characteristic of how you teach them about their disease.
And this MET-L thing, where does it fit in the transplant world, like post-transplant? Are we going to say they fit more with the alcoholic liver disease and go with those kind of post-transplant options?
No, I mean, it's both, right? So I'm starting to use it again, because clinically, I don't see that upper bound as being that important. So in transplant, I mean, we talk about patients going to transplant who have MET-ALD that have both cardiometabolic risk and alcohol excess. But it's really just use of terms. I don't know if there's going to be a need to have a specific ICD code for that. That's something that we're thinking about now. I'm not sure it's going to be necessary to do that. I think you just code both. Yeah.
And the last question is, now, there's a lot of influx of all this fatty liver patients in the clinic and waiting time. And now we're trying to educate the primary cares to do the ELF study and the FIB-4s. Right. My only concern with that is we've been telling them that if the ELF and the FIB-4 doesn't show any fibrosis, you're good. You can just manage the metabolic, derangements and try to prevent progression, etc. But if you're taking patients in the population of 20s and like I see in Texas who have fatty liver disease and 25, 30 years old and telling them your FIB-4 and ELF is okay, so you're good, because they're more likely going to have all this fibrosis and everything develop at 30, 35.
Yeah,
what's your take on?
Right. So you can't really use FIB-4 in people less than 35 because the accuracy is about 50%. So you can't use it in people who are young because age is a factor in that equation, and it'll inappropriately downgrade the risk. So you just can't use it in those patients, unfortunately. But you can reassess them. And the problem in Texas is that you have a high prevalence of Hispanics with PNPLA3 as well. So you have probably a higher risk population at baseline than other places do. So you unfortunately have to reassess them clinically or with other measures, liver stiffness measures.
All right. Thank you so much.
Mm-hmm.
Thank you. I think Dr. Masumi has a question as well. And then maybe if anyone else, please raise your hands. Otherwise, after that, we're going to close. Dr. Masumi, please.
Sure. No, I just have a quick comment. First of all, going back to the liver biopsy, I think if we have approved meds, which would indiscriminately be a new medication, and you're going to put somebody on a new medicine for a long time, and there's always an unknown with the new medicine, we have to stick to the best modality to assess both steatosis and fibrosis in the liver, which would be liver biopsy. And I think both in the society and in pharma and in insurance companies, there are people who would force us to do more liver biopsy, because majority of this non-invasive tests are very ALT dependent. Whether even like a fibrous scan is ALT dependent. So that's about the liver biopsy. Number two, I wanted to just say something about the word fat. A stigma is horrible, all right? A stigma is a terrible thing. But the word fat is not a stigma necessarily. You can't just take the word fat out of the equation. When you see that 25-year-old who's drinking a 16-ounce of real Coke or Diet Coke, doesn't matter, every day, and he's getting bigger and developing abdominal adiposity, and his education is average, you got to use the word fat right in their face. The same as we use the word alcohol. The same as how my parents used to yell at me when I was not doing my homework. So because like I just looked at the website they put up and it's amazing. Thank you so much. I'm going to use it because it gives access to dietitian. They have Wita. But you go through like 10 clicks on that website. You don't use the word fat. You don't use the word weight barely, unless if you go to calculation. But that's the bottom of the condition is we eat too much and we eat bad food. So we can't like sugarcoat the disease based on new nomenclature.
No, and I use the word fat. I do talk about fat in the liver. I definitely do talk about that. I don't think you don't have to not use the word fat anymore. That would be silly. I mean, of course we should, it makes sense to use that word. I think the stigma more relates to, how you describe it to, your family and your friends. I have fatty liver versus I have SLD or I have MASLD or whatever, just give it whatever name you want, but it's not fatty liver. The first time I really realized that it could be a problem is I was actually seeing a study patient. And my coordinator, the patient had just finished the trial, and the coordinator looks at the patient. She goes, "Oh, well, you don't need to see her here anymore because you just finished the study, but you can just see her in fatty, right? And like in fatty clinic." And I was just like, you know what I mean? It was just, and this poor lady, this poor overweight woman it was just very awkward, right? So I think it just depends on how you use it. I mean, you can talk about fat in the liver, but I think saying somebody is fat is not really the best way to say it. And then with respect to biopsies, I do want to touch on that. I am fairly involved in this space from a pharma and regulatory perspective, and I do not have any impression that the FDA will put in their label the need for a liver biopsy. I have not seen that ever, and that is not the expectation, and that's not the expectation from payers either that I've heard secondarily from. So I don't think we're going to see a need or a requirement for liver biopsy unless they price the drug so high that the insurance companies are trying to put barriers to do that, like they did with Hep C early on, right? So I hope that they don't do that. That would be very stupid for them to do that. But who knows what they'll do. That would be the only caveat to that. And I do think that the work with non-invasive tests to identify at-risk disease like Agile-4 or like FAST or MAST, those calculations that combine serum with liver stiffness measures will get us what we need to be able to prescribe those drugs. I don't think it's not going to be biopsy, but I would be shocked.
Sure. No.
You can come to Chicago and
it is in the gray zone because obviously if your KPA is 18, your AST is over your ALT, you have a little bit of nodularity, like things that.
But then you can't have it because then you have cirrhosis.
Yeah, exactly. So, but when it goes to the gray zone, hopefully they don't ask for it. All right, thank you so much.
Sorry, I know we're running out of time. Can I make a quick comment based on what Dr. Rinella said at the very end? I was having a meeting with the CEO of the Magical company, and he raised this issue of the cost of the medication. What he said is very interesting and very practical. He said that based on his experience, he does not get a pat in the back if he lowered the price of the drug, because the way it works in America, and revenue comes from America, the insurance companies and especially the PVM, they actually want the drug price to be higher so that they can get a bigger discount. If you make the price lower, and they get upset. So keep that in mind. I think as a society, you need to have a discussion later on. And so that's a reality.
We have no, President, we have no impact on what they decide to charge for their drugs. I mean, we have absolutely no say. But I will say, if we use Hep C as a correlate, I mean, that was a problem, if you remember. I think you're old enough to know that, right? I don't know. I've been working with you for so long. I think you are. So it was definitely a problem at the beginning. Remember, they really made it difficult. So we have no control over that, but there is a balance. I know they're doing a lot of market analysis to what the market will bear. I mean, but I hope that we don't have to do that to patients. I think that would be not right from a risk.
Said that he realized that if you make it lower, I mean, you'll think about it, but that's what they're thinking. Now, coming back to one very, I wouldn't ask anybody to do it, but one of my colleague in the same context told the patient, "You are fat," and then cried, and patient comes back in 6 months, patient is 50 pounds lighter. I said, "What happened?" "I was told I was fat and cried, and it worked."
Oh, but it usually doesn't work, though. It doesn't work.
I know.
People.
I'm not recommending anybody to do it. It's just, that was a shock to me. I know we never say that to the patient, and you should not.
Yeah, I shouldn't stigmatize that one. But thank you for joining, and thank you everyone. Otherwise, this is fantastic. This is a great discussion, great crowd today as well. And Dr. Rinella, thank you. You are the pioneer in this. You led this, and convincingly to the world and to all the societies, you showed the way that this needs to be changed the right way. This is the way, and we all are very thankful for all the work that you have done so far. Again, thank you so much.
Thank you very much. And thank you for the invitation. It was a lot of fun. And now I'm awake. Now I can seize the day. Okay. Thank you, and have a wonderful day, evening.
Thank you. Bye-bye.
Thank you.
Bye-bye.